Janab, good afternoon and good evening. Welcome everybody. मेरे साथ I have a wonderful guest, Dr. Anthony Leeds, visiting professor of Faculty of Science, University of Copenhagen में. आप इंटरनेशनल मेडिकल यूनिवर्सिटी कोलालमपुर मलेशिया वगैरह में भी से भी मुंसलिक हैं. इस वक्त उनका इंटरेस्ट जो है और जो रिसर्च में वो हिस्सा ले रहे हैं, दैट इज़ मोटापे के हवाले से जो लो एनर्जी फूड्स का इस्तेमाल है उसके ऊपर रिसर्च कर रहे हैं एंड लो एनर्जी डाइट इन द वेट मैनेजमेंट क्लिनिकल रिसर्च इसके ऊपर कर रहे हैं. आप कॉलेजेस ऑफ पार्कर इंस्टीट्यूट से भी मुंसलिक हैं. इसके अलावा कोपनहेगन की यूनिवर्सिटीज़ कॉलेजेस यानी व्हाट अ ग्रेट मैन. He was a senior lecturer at the King College London until September 2007, medical director for the Cambridge Weight Plan until March 2019, and is now chairman of TDMR Europe, the European industry group that works with the European Commission. हमारा आज के प्रोग्राम करने का our objective is because of our lifestyle these days and the food intake, what food we use, and as I said before, our lifestyle, it all results in the weight gain. And many people, they don't realize where this obesity starts and how is he obese or not. Dr. Anthony, I welcome you to the show, and how are you today?
I'm fine, thank you very much.
Beautiful. I'll go straight to my subject today. Obese. What is obesity, and please do explain to us how people find that are they in that are they obese or not?
Obesity is a condition where the body accumulates too much fat and it accumulates it in the wrong places. So there are normal places where fat is laid down under the skin, subcutaneous region, and also in the abdominal organs and so on. However, when there's an excess amount, it spills over into other organs like the liver and the pancreas. When it fills the liver, it can give rise to fatty liver disease, which can be a very serious disease, and gastroenterologists throughout the world are now seeing very many more cases of this condition. And when it spills into the pancreas, various other things happen. There's an increase in inflammation, there's a reduction in the capacity of the beta cells to produce insulin, and so gradually there's a reduction of function. So an individual over a period of 10 or 15 years drifts slowly from being completely normal through pre-diabetes to becoming diabetic. Of course, this year is a very important year because it represents the centenary of the discovery of insulin, well, the start of the experimental work in Toronto that led to the discovery of insulin, and then the first use of insulin in 1922 by a team at the University of Toronto. So this is a very important year. The discovery of insulin was a landmark discovery, and my view, although I may be a little bit biased because I've spent the last 15 years working in the area, is that the use of special diets will be a very important contribution to the management of diabetes.
So in other words, very interesting, what do I understand is like once I see my body, apparently I can see deposition of fat on the hips, on my tummy side, or on the arms. But this means inside my body, this fat is deposited on the organs as well, as you said, on the liver. Is that right?
That's correct, yeah. Or wow. within the liver, and that has effects on its metabolism. And if there's too much there, eventually, then it doesn't function very well at all. And there's an increasing recognition of this. And of course, we know that weight loss, a sufficient weight loss, will greatly reduce it. Now, in the United Kingdom, we have colleagues have recently undertaken a very large trial to try to achieve diabetes remission. And this has been run by Professor Mike Lean in Glasgow and Professor Roy Taylor in Newcastle. And some of the participants have been scanned with MRI scans to look at the liver, to look at its size, the amount of fat in it, and likewise the pancreas and the amount of fat in it. And one of the interesting things is that if you achieve sufficient weight loss, and if you maintain that weight loss, you can reduce the fat in the liver, you can reduce the fat in the pancreas, you can achieve a reversion towards normal. You can indeed make people who have had diabetes for up to 6 years revert to not having diabetes. And if you achieve weight maintenance, then you can maintain that state. And this is a very important finding that was published 18 months ago, and it is already being rolled out in the United Kingdom as a potential way of reducing the number of people we have here in the United Kingdom who are in the early stages of diabetes. So it's a very important step that we've made recently.
So, in other words, if somebody's waistline is gone too much, so don't
Right.
think
Yes.
that it's only fat on the top. This means there must be fat on the organs as well. Wow.
Yeah.
What are the causes of obesity?
The current view is that around about 70% of the causation of overweight and obesity is related to genetic factors. And I'm sure that there are many people who recognize that some of their relatives are a little heavy and that they're perhaps replicating the same pattern of weight gain. About 30%, 25-30% is related to environmental factors. So that is the energy intake, the type of food that is consumed, and then also physical activity. I think one of the interesting things to consider in relation to this issue of the preponderance of genetic factors is that bear in mind that we're all descended from hunter-gatherers who actually lived quite tough lives. There were very small numbers of them, measured in thousands rather than tens of thousands, and they actually had to hunt and to scavenge for their plant foods. They would quite often be hungry, and they were faced with famine, if you like, for frequent occasions, and quite seriously. So those of us who survived through that, who are descended from those people, are actually selected to be able to survive famine. That means that our energy conservation systems in the body, the metabolism, is super efficient. It makes us predisposed to gaining weight when there's plenty of food about. And of course, in the last 150 years or so, fortunately, the agricultural systems and the food production and food preservation systems mean that in fortunate parts of the world, there is a continuous supply of food. Of course, there are parts of the world where food supply is a bit unsteady, but part of the reason is the excessive availability of food at all times.
Dr. Leeds, as you said, that 70% is genetic contribution, and 25% all other factors, and then 5% something else. So this means if it's in my genes, no matter what I do, I got to be fat. Is that right?
Well, it means it's going to be a struggle. However, it is possible to alter the environmental factors, and this, of course, can occur on different levels. It can occur in the public health domain, if you like, where we can look at issues like the advertising of food and food retail practices, the composition of food, the energy density of food, and something that is I think an important factor is portion sizes, that both in terms of portion sizes that are sold, that are served in restaurants, and that we even serve ourselves at home can be too large. All these factors can be manipulated. So that's food. We can also, if we find ourselves to be heavy, we can reduce that by going on a reducing diet. Conventional reducing diet is to achieve an energy deficit of 500 to 600 calories per day. But over the last 15 years, I've been working on types of diet which achieve, say, 1,000 calories or slightly more energy deficit per day in order to achieve faster and more effective weight loss. And the importance of that is that we know that the amount of weight loss that is needed to achieve some of the health benefits is actually greater than most people will achieve using a conventional diet. So partial use of meal replacements, that's formula diets, soups and shakes and so on, or a complete use of those for a short period of time, can be beneficial in osteoarthritis, in reducing weight, reducing the load on the joints, reducing the inflammation and the pain. In diabetes, it can result in an improvement in the metabolic state. And as I've said already, we've proved in some very good randomized controlled trials that you can actually achieve remission of early diabetes. That is a major advance.
Great. So this means it's a good thing. So I can change my fate, although it is 70% genetic factor. But if I change my habits, I can change my fate, and environmental factors by altering environmental factor, I can control my weight. So that's what I understood.
Yes.
Now, you're already talking about diabetes. What are the health factors linked with the obesity?
Diabetes is probably the one which globally at the moment is of greatest concern, but bear in mind we also have an aging population globally in most countries in the world. People are surviving longer, and of course osteoarthritis is a condition which affects millions and millions of people worldwide. It is one that causes decreased mobility and eventually social isolation, and I work in the Arthritis Institute in Copenhagen, where we've undertaken some clinical trials and have shown that if you can achieve weight losses of 10 or 12%, that's around 10 kilograms in people starting off just a little over 100 kilograms, that you can actually reduce the pain, you can make them more mobile. In our biomechanics lab, we've shown that you can reduce the load on the knee. For every kilogram of weight loss that you reduce, the body weight, you reduce the load on the knee with each step by about 2.1 kilograms. So if you imagine 10 kilogram weight loss, you're reducing knee load by 21 kilograms, so a disproportionate beneficial effect. And the important thing also is quality of life definitely improves. We've measured it with the appropriate questionnaires. And when I've spoken to some of the participants in these trials, they tell me that they're now much more mobile, much more socially integrated. If they play with their grandchildren on the floor, they can now get up off the floor, which they couldn't previously do. And some of them have been able to get back on their bicycles and cycle around Copenhagen. So they are very much happy people. And the next thing is, can they maintain it? Because of course many people criticize saying, well, you achieve a good weight loss and a good short-term result, but how can you maintain it? And the answer is, several groups around the world have been working for some time now to try to achieve weight maintenance. We know some people struggle a bit more than others. We have information now which helps us to help those who struggle more, and we are able now to say that we have, in the clinical trial that I just described, maintained the 10% weight loss in just over 2/3 of them for 4 years, and we've also maintained the reduction of pain in the joints as well.
In your previous conversation, you did mention remission of diabetes.
Yes.
I always learnt in my life, or that's what I thought, that diabetes can be controlled, it cannot be cured. So what does remission mean? Do you mean it's cured?
No, we have to be very, very careful not to refer to the state that we achieve in these clinical trials as a cure. It is not a cure. It's a remission of the metabolic state. Now, first of all, we have to bear in mind that by the time somebody has a diagnosis of diabetes, that's type 2 diabetes, they have probably been drifting towards it from a metabolic point of view. In other words, initially their insulin's been going up and their glucose is then going up for about 15 years. And of course, there are some other changes that take place in the body as a result of diabetes, changes to blood vessels, for example. And when you rapidly change the metabolic state, of course, you do not make those other changes. Now, we have good reason to believe from our results from 2 years into this trial that some of those other consequences may well be improved. We know that risk factors for heart disease improve. We know the blood pressure goes down and blood lipids can be improved as well. So the risk of cardiovascular disease definitely goes down if somebody reduces weight by about 10% and maintains that weight maintenance. So we are not referring to cure, we're referring to remission, which means an improvement in the metabolic state. And for remission, it means the blood glucose, of course, goes back to normal. So metabolically, at that point in time, the individual no longer has diabetes. Okay. They are what we call diabetes in remission.
Okay. Now, as Dr. Leeds said, that these are the sicknesses. Of course, diabetes is number one, and then arthritis, and then high blood pressure, and of course heart conditions. These are all linked with weight gain. Now, my question over here is, what should someone do to control obesity or to prevent weight gain?
Prevent. So we have to draw a distinction between prevention and reduction of weight once it has been gained. Prevention is an issue that in giving guidance to individuals, we should warn individuals that there are points in life where there's a tendency for people to gain weight. So some examples would be the weight gain that occurs after pregnancy, the weight gain that occurs when an individual moves from an active occupation to being sedentary and sitting at a desk. And of course, one of the things that we've seen during the COVID pandemic is that many more people who would have been more active, walking out, going to meetings, have been stuck at their home desks. And we know from the surveys that there has been a rise in obesity and overweight as a result of that. So being sedentary, not being active enough. And then another interesting one, I think, is that we're encouraging everybody to be very much more physically active. But of course, occasionally injuries occur, and somebody who's very active who has an injury that stops them being that active may well then gain weight. And I've certainly seen that happen among some of my patients.
Sahab, I think we must listen to it very carefully. Now, yes,
sorry. So I was going to say that's as far as prevention is concerned. So being aware that there are points in life where weight gain occurs, occasionally measuring weight and noting when it goes up, and when it gets to the point of being concerned, then it would be wise to seek advice. Now, where do people get their advice from? Well, we know from surveys that people often use information in newspapers and magazines, and there are celebrity diets and people follow them. And the real problem there, of course, is that the majority of those are not supported by expert help. My view generally would be that diets should only be used if they are supported by good, high-quality experimental evidence, and that certainly doesn't apply to some of the celebrity diets. But if there is good experimental evidence, that's great. Majority of those types of diets that have been used in clinical trials will be ones where there is support from a healthcare professional or dietitian, where there is an educational program, and you would never give a dietary program without guidance on physical activity, and then guidance on the behavioral aspects of how to maintain weight subsequently. In other words, the things to do and perhaps not to do in order to avoid subsequent weight gain. And we always have to accept that weight maintenance is a challenge for many individuals, and that people will sometimes regain weight after they've lost weight. And I think healthcare practitioners and scientists are now recognizing that we need to adopt the same approach as with smoking. So smoking cessation programs, people stop smoking, but some of them restart. So we do the program again. They stop smoking for a while, then they regain again for a while. And of course, you don't say, no, you can't do it because you've reverted to smoking. You say, well, let's try again. And we need to adopt the same approach for weight management. And that also means monitoring. And in one of the trials that's been done recently in the UK, we had a system whereby if there was a 2 kilogram weight regain, that's about 4 pounds, that you would give them extra advice and guidance and sort of reinforce the information they had. If they regained 4 kilograms, we would actually allow them to use a formula diet or meal replacements again for a few weeks in order to lose the weight that they had just regained. In other words, we recognize that people can regain weight. Now, the other interesting thing is that we also are beginning to sort out people who are more prone to weight regain. We know there are differences in the way the hormones in the gut signal to the brain between those who find maintaining weight more difficult than those who find it easier. We also know that there are behavioral differences as well. We know that individuals who are more impulsive in their behavior are more likely to regain weight, whereas those who are more controlled are perhaps more likely to maintain weight. So there's an increased understanding, and therefore, as a consequence, an increased ability to give appropriate advice and guidance.
So there is a red flag, even if you, as Dr. Anthony Leeds said, that if you gain 4 pounds, so there is a red flag that they advise a different kind of food. Now, Dr. Leeds, you have good experience. Just guide us, if somebody wants to lose weight, what should they do?
I think it's always best, if they have not seen their medical practitioner for a while, to actually go along and say, actually speak to the healthcare practitioner and say, look, I think I'm too heavy, I need to lose weight. Do I have any health issues that are weight related? Can appropriate measurements be made? And what sort of guidance do you think I should follow? Now, we're at this point now where we have to consider the amounts of weight loss, because as you walk along the streets of Toronto, you will see people of different shapes and sizes, and there are people who obviously have much more weight to lose than others. And then this takes us to the question of, well, what are the approaches? Is diet alone going to be effective? Would we have to use medications? And for some individuals, would surgery be appropriate? Now, the medical practitioner will, of course, guide the individual along the appropriate pathway. We'd usually start with diet. For some individuals, there's usually a great deal of scope for diet. And I've seen individuals who hadn't really thought about what they were eating and the types of food they were consuming and the times of day that they were eating and so on. And when they made changes, they had a terrifically good response. And I've seen individuals lose 10 or 15 kilograms simply by making appropriate dietary changes. There are others who struggle, and at some point, the doctor or the healthcare practitioner might make a recommendation that one of the medications might be used, one of those that is available in North America to help people either to suppress appetite or to modify metabolism. And then, of course, for individuals who meet certain criteria, who are heavy, very heavy, we do have specific thresholds written into clinical guidelines, they may then be considered for bariatric surgery. And of course, there are different types of bariatric surgery, and the specialist team will have discussions with the patient about with the individual about what are the options and which one might be most appropriate. So there are now a whole range of options.
In other words, money talks. If you have, because some procedures are not covered by WHIP here, and if it's something cosmetic, you have to pay it. You can, that can help you. Now,
A point there, you mentioned cosmetic surgery, but in actual fact, what I'm thinking of here is only the surgery of the type which is designed to cause weight reduction. Cosmetic surgery is a different issue, and of course people are free to use cosmetic surgery.
No, I understand, but for the weight loss, there are certain surgeries. If, of course, it's a red flag and somebody is overweight, then these procedures are covered by OHIP. But if somebody wants to do, for example, if I want to go some kind of surgery where I want to liposuction or something, that is, people have to pay from their pocket. I have one concern, Dr. Leeds. When I was young, my lifestyle was very active. I was very active in life, and I had a control on my appetite as well. I could, control my food, rely more onto the water. But with the age, now I feel like eating something. Or when people are sitting home, they have nothing else to do. Is there any way we can control those things?
I'm not sure that there is really clear evidence that appetite changes with age, other than obviously taste can alter in old age and so on. But we're talking really about younger and middle-aged rather than the very elderly. It is important to notice that with age, there's a tendency for the lean mass in the body to go down, so the amount of muscle in the body goes down unless people are working really hard to maintain it. And the effect of that is that the amount of energy that the body needs at rest goes down. So we measure this by asking people to keep still for a while and then make the appropriate measurements. And with age, muscle mass does go down. Now, one of the important things is, again, with an aging population, we're becoming much more conscious of the fact that this occurs and trying to identify people who have lost too much muscle mass, because, of course, if you lose enough, you become unsteady, you don't walk very well, you may be at risk of falls, and we don't want that to happen. But as far as appetite and wanting more foods, I think may also be related to lifestyle issues, and I do think that television and screens play a big part here, and when people are watching television, there may be a tendency to consume food without being really aware of how much is being consumed. I've done some experimental work on that a long time ago, where we showed that individuals would snack much more and consume much more energy if they were watching the television than doing other tasks.
And I think another thing is, I was used to eat this much, but with the age, my my metabolic rate is not as efficient as it used to be, so the extra food is stored, and so with the age people should reduce their portions of food. Is that right?
In order not to gain weight, but it's also very important to then consider diet quality, because one of the dangers would be that reducing the total amount of food might reduce the total intake of critical nutrients. So it's quite important to ensure that what is eaten is of high nutritional value. And of course, many carbohydrate foods tend to have perhaps less of the essential nutrients in them. And so the general tendency now, although it hasn't perhaps moved totally into the dietary guidelines, is that we should consume less carbohydrate foods, a little more protein, and the protein foods are likely to be associated with more micronutrients.
So what would you suggest? What are the safe diets?
Safe diets. Well, the general statement I'd make is that the diets that it would be safe to use are those that have been properly tested. A safe diet would be one that delivers or that causes a 500 to 600 calorie dietary deficit per day, unless it's one of the formula diet programs where you would deliberately aim to achieve a larger dietary deficit, but then that would be supervised by individuals who know how to manage those diets. A safe diet would also deliver all or most of the micronutrients on a daily basis. Now, it's interesting, I did mention celebrity diets earlier on. If you look along the rows of books that describe celebrity diets, not all of them will meet that requirement of providing the micronutrients on a daily basis.
Thank you very much. Dr. Leeds, we will definitely continue this segment in the next program, and I hope, I wish all the best to all our listeners. You must watch your weight. You must be careful what you eat. How many calories do you need? How much you consume? So, and as Dr. Leeds suggested, everybody must have a weight machine at home, so that if there is something, you should know that how many pounds are you gaining. Dr. Leeds, thank you very kindly, and I'll definitely talk to you in the next program about some of the sicknesses linked with the obesity.
Thank you. Thank you.
Thank you very kindly for your time, though. Bahut shukriya, and you must look after yourself. You know what? If you're happy, you're healthy, that makes the difference.
Indeed.
Please, we'll see you next program. God bless. Allah Hafiz.